at Abigail Wexner Research Institute at Nationwide Children's Hospital. I'd like to welcome everyone to the second talk in this new webinar series called Connect and Learn, jointly put together by the Ohio State University Center for Clinical and Translational Services and Translational Science and RISI at Nationwide Children's. So the main goal of this webinar series is to connect behavioral health researchers, digital health researchers, and technology providers so we can learn from each other and potentially collaborate on research proposals or other clinical research activities. Again, I'd like to thank Dr. Kat Houghton, CEO and co-founder of IllumiView, for kindly connecting us with several clinical researchers and hosting the first 4 webinars. A few logistics before we can get this started. We are recording this webinar and we'll make the recording available to those who missed it. The presentation is about 35 minutes, and after which we'll have a 10-minute Q&A session. So please hold your question until the Q&A session, or type in the chat box. Then use the Zoom raise hand feature when the Q&A session is up. Now I'd like to welcome Dr. Kat Houghton, CEO and co-founder of IllumiView, to introduce our speaker for today.
Thank you, Youngwei. Thank you. Yeah, so my name is Kat, and I co-founded IllumiView in 2009. We provide the MIMA system. Some of you may be familiar with it, and that's how I met Andreas. He's been using the MIMA system, so mobile ecological momentary assessment, for the last, I think, 2 years. Are we up to, Andreas? It's been more than a year. And so that's how I met Andreas, and thought he would be a great person to come and present to this group, as he's really been digging into the front lines of digital methods and behavioral research. He was one of our first clients to use the Garmin integration, which happened about 2 years ago, where we started pulling in physiological data from wearable devices into the ecological momentary assessment app. So he's got a wealth of knowledge about not only diabetes, which is his area of focus, but also digital behavioral methods. So I know Andreas currently is a postdoctoral researcher at one of the largest diabetes centers in Germany. Is that correct, Andreas?
Yeah, that's quite correct. Thank you very much.
So tell us a little bit more about your background, and then we'd love to just jump into your presentation.
Yes, perfect. So shall I try to share the screen right now, huh?
Yeah, if you,
that may make sense.
Let me know if you need technical support.
Let's see, time.
There we go, perfect.
Okay, you can see the presentation now?
Yes.
Great, okay, so yeah, thank you very much for the kind introduction, Catherine, and a very kind welcome to all the participants and listeners of the presentation today. And I'm very pleased to have the opportunity to present here about our research about the DIALink studies. That is behavioral research in the field of diabetes and diabetes psychology, mental comorbidities and their impact of diabetes and the diabetes outcomes. Why studies? Because we had the DIALink 1 study regarding type 1 diabetes initially, and now we started a second study regarding type 2 diabetes, applying the same research approach. And it is quite new. I think an approach like that hasn't been applied in the field of diabetes psychology yet. So it is quite innovative in comparison to what has been done before. So just to tell you a little bit about myself, I'm a postdoctoral researcher in a research institute. It is located in southern Germany, affiliated with not with a university in itself, but with the largest diabetes inpatient center in Germany. It is in Bad Mergentheim, a small town in the south of the country, and we have a large hospital here, the Diabetes Center Mergentheim, which provides treatment to inpatients in a tertiary care setting, about 4,000 adults per year, and we have also an outpatient center with about 16 to 17,000 people with diabetes treated in an outpatient setting at this center. And it also has different other facilities, including the research institute. It is a private hospital and a private research institute with a smaller research group under with the 2 heads, Norbert Hermanns and Bernhard Kulzer, Thomas Haag, he's the head of the hospital. And then there's a couple of researchers doing, well, different projects in the field regarding mental comorbidities, regarding treatment programs, educational programs, and also assessment tools, questionnaires, and different survey tools in the field of diabetes and patient-reported outcomes. And we are really interested in comorbidities such as depression and other mental disorders, but also symptoms and diabetes-specific problems in these people with mainly type 1 and type 2 diabetes. And I prepared a couple of slides to introduce the field a bit further, because the chronic condition diabetes may not be quite well known to everybody. I mean, of course, you're aware of diabetes, diabetes, but what does it really mean? What is type 1? What is type 2? Every type of diabetes has the common characteristic of high blood sugar, which is caused by either too little insulin being secreted or too little insulin activity, too little insulin sensitivity of the tissues. So the effect of insulin, which is actually kind of opening the cells and enabling the sugar from the blood getting into the cells and being taken by the cells and being taken up, is not possible for different reasons. In type 2 diabetes, it is mainly a problem of the tissues not being sensitive to the insulin activity or insulin action anymore. And in type 1 diabetes, it's mainly the problem that the pancreas, the insulin producing cells of the pancreas are killed by an autoimmune process. And so it is too little insulin or too little insulin action resulting in high blood sugar, and high blood sugar over time also results in significant risk of long-term morbidity, long-term complications of diabetes, affecting the vessels, resulting in eye disease, kidney disease, nerve cells being affected, and a lot of other issues, macrovascular complications such as heart disease or heart attack and stroke. I'm telling you a little bit more about that later on, but there's really a significant impact of diabetes if it is not treated well, if it is not controlled well. And the main specific of diabetes compared to other chronic conditions is that the treatment of the condition lies primarily in the hands of the people affected by diabetes. I mean, the doctors and the healthcare professionals support the person and find in collaboration, find the right treatments, the right treatment modalities, the right medical treatments, but still conducting the treatment day in, day out lies in the hands of the affected person. So if you don't treat your diabetes well, you will probably end up with significant complications and poor long-term health outcomes, even reduced life expectancy potentially. So this is a real concern. And yeah, the main two types are type 2 and type 1 diabetes. Type 2 is more common. It is about 90% of all diagnosed cases, while type 1 diabetes is less prevalent with about less than 10%. And then there's a few other specific types, but these are negligible. They are rather rare in comparison to these major types of diabetes. As I said, type 1 diabetes is defined by the loss of beta cells, of insulin-producing cells of the pancreas, whereas type 2 diabetes is characterized by low insulin sensitivity or reduced sensitivity, reduced sensitivity of the tissues, so the action of the insulin is not there, and the cells are not opened, the sugar remains in the blood and results in a negative impact on the vessels. And then in addition, there's also acute complications that can occur in states of significant high blood sugar, hypoglycemia, or significant low blood sugar, usually caused by the treatment. If you overtreat by, for example, over injecting insulin, then you can end up in a coma or in unconsciousness state. because of low blood sugar reactions. So there's a link between the quality of glucose control, the quality of, or the near normal range of blood glucose in people with diabetes. HbA1c is a laboratory value kind of defining the mean glucose levels over the past 8 to 12 weeks of living with diabetes. In people without diabetes, the HbA1c value would be below 5.5. And in people with diabetes that isn't treated, it would be above 6.5. And then there's kind of a gray zone in between. In people with diabetes being treated, the value can be lower than 6.5. That would be kind of a good result if it's not associated with risk of hypoglycemia. But generally speaking, you would try to get a value below 7.5. That is quite okay. Lower may be better if it's not associated with risks. But higher values are associated with increase in and excessive risk of long-term complications, as indicated by the red area in this diagram. There are differences in the types regarding the treatment, but to stay with the topic of complications, there's an excessive risk. You can see in the diagram here, HbA1c is written there between 6 percentage points and 12 percentage points, and you can see as the risk increases excessively in the double-digit area. For retinopathy, that's the eye disease caused by the small vessels in the retina growing excessively and affecting the eyesight. Nephropathy, which is the kidney disease with the filter function of the kidneys being lost due to the glucose impact on the small vessels, and neuropathy, that is the nerves being affected, mainly the long nerve cells in the legs or in the arms, but mainly it's starting with the legs. The longest nerve cells are affected initially, or first of all, and you may have negative sensations such as pains or unpleasant sensations or loss of sensitivity, so you don't feel the pains anymore, you don't feel the pressures anymore and stuff like that. That can also have significant impacts or increase the risks of significant wounds not being realized, recognized, and this can also result in significant problems. There's aspects such as stroke, such as heart disease, heart attack, and peripheral arterial disease, and other aspects, skin, teeth, a lot of aspects which can be affected by diabetes if it's not controlled well. Then there's the risk of hypoglycemia. For example, if you inject too much insulin, you may end up in a kind of a coma or unconscious state. You can hurt yourself falling down, having a car accident and stuff like that. So people are often concerned about hypoglycemia. Then there's a risk of ketoacidosis, particularly in type 1 diabetes, but also type 2 if it is insulin dependent. You can end up in a coma. You can die from the coma if you are not treated. You may not wake up again if you get into the ketoacidosis, which is a result of too little insulin being available and the cells starting to burn fatty acids instead of sugar, resulting in setting free acidic products of this process into the blood. And you can imagine that all these risks and impacts and problems may result in significant burden and psychological problems such as depressive mood or tiredness, fatigue, or specific fears, and feeling overwhelmed or having problems of accepting diabetes as a part of one's life, integrating the impact and the problems and understanding oneself as a person with diabetes. That can be really demanding for people. And now to get back to the topic of depression, we find, similarly to many other chronic conditions, we do find higher rates of depression in people with diabetes. That's not too surprising. It is depending on the literature, you will find up to doubled prevalences, maybe a little bit less, maybe 50 to 100% more depression prevalence in people with diabetes compared to those without. And also a lot of people with minor depression or elevated depressive symptoms, which are not meeting the criteria for clinical diagnosis, but still may impact, first of all, quality of life, but also predict poor outcomes regarding diabetes, as depression is associated with less optimal outcomes in diabetes. There's longitudinal studies such as this one, which have been summarized in one meta-analysis in 2019. I'm only presenting this slide, but there's further longitudinal research confirming this aspect, that comorbid depression in diabetes is associated with elevated risks of microvascular complications and macrovascular complications. Micro, that is the small vessels in the eyes, retinopathy in the kidneys, the nephropathy and the nerves regarding affecting the nerves, the neuropathy, and macrovascular complications are stroke, peripheral arterial disease, and heart disease, for example. So there's elevated risks of these long-term complications if diabetes is associated, is accompanied by a depressive disorder, higher depressive symptoms. There's also associations with less optimal glucose control, operationalized by the HbA1c value, the long-term diabetes glucose control value. Although the literature is not fully consistent in this regard, there's also studies which don't find the correlation. Some studies consider further aspects, variables beside depression or depressive symptoms. You may distinguish between depressive symptoms and depressive diagnoses. So there's a lot of heterogeneity in the literature, and it's not quite clear whether you would say there's a direct association, or maybe we are not finding the right moderators or mediators in this relationship. But tentatively, depression may be associated with less optimal glucose control. When looking at this association and other associations of depression in diabetes with poor outcomes, the other effective variable or core psychological variable that has been considered, and that has now a rather long research tradition of at least 20 years or so, is diabetes-specific distress. This is not a syndrome or disorder. It is kind of a sum of quite diverse, potentially quite diverse diabetes-specific problems and burdens. People suffering from having their diabetes, feeling overwhelmed, feeling greatly discouraged after years and years of treating their diabetes, maybe treating their diabetes quite good, but then they get more and more discouraged after 20 or 30 years, not getting to any good result, just doing it day in, day out. Then feelings of restrictions regarding one's choice of foods, regarding one's daily living, the decisions you want to take, always being dependent on what your glucose levels do, how you integrate your diabetes and your glucose control with your activities. You may have to stop specific activities due to low blood glucose and stuff like that. Then disappointing experiencing, for example, you treat your diabetes well, but still measure poor results. You cannot control diabetes 100%, so you may have poor glucose values despite doing everything as good as you can. People may experience problems of accepting their diabetes, avoiding everything related to it, neglecting their treatment, not being able to integrate the condition into their life and into their self-concept. Then there's interpersonal problems, including stigmatization, hypoglycemia, hypoglycemia-related fears. People may be really concerned and worried about getting into hypoglycemia, even if they haven't experienced it at all, or even if they don't really have the high risk for hypoglycemia, but they may still be really concerned and worried about it. And then there's one significant aspect which really strikes out, that's fear of the complications, as these significant long-term complications, losing one's eyesight, getting dependent from dialysis due to kidney disease, losing one's sensations in the fingers or in the feet, or even amputation, which often occurred a longer time ago, still occurs, but not as frequently anymore because medicine has increased, has improved. But still, there's the fear of these significant, severe complications. And it's kind of the so-called Damocles sword that's hanging just above you, and you cannot control it. You're feeling it could just come down and hit you. So this is really striking. As I said, this variable of diabetes distress, it's not a condition, not a syndrome or diagnosis. It is operationalized by questionnaires. One of the core questionnaires is the problem areas in diabetes questionnaire with 20 items. I don't want to go into the details here, but it's diverse problems that people can experience regarding their diabetes. And if you get to the cutoff score, we psychologists will say, okay, there's elevated problems, elevated diabetes distress, and this may be a problem, maybe associated with risks potentially. That's what interests us. How common is that? Diabetes distress can be found in approximately 30%, up to 1/3 maybe, of the collective of the population that we see here in our center. On the other hand, it's tertiary referral center or tertiary care. So people may be more clinically severely affected here, but still in primary care, you will find between 10 and 20% at least. So it is quite common, and you have people with mildly elevated, but then also severely elevated diabetes distress. And this is usually associated with some kind of poor outcome or poor diabetes control. You can look at the single items of the paid questionnaire and the specific problems. You will usually find this significant peak here, which identifies the worry about possible future complications of diabetes. So you can see fear of complications is one of the core aspects, but then there's also worry about hypoglycemia or problems not having clear concrete goals, just treating diabetes day in, day out. Where do you go? Nowhere, you're just doing it again and again to stay healthy. But that may be frustrating, but you're not really rewarded or getting to any point, any outcome. It just can get worse. And other aspects such as feelings of guilt, feelings of anxiety when you're not doing as good as you could do, treating yourself as good as you could do, and stuff like that. So this is type 1, type 2, quite similar, some differences, but I think in several aspects, the mental problems that are common in people with diabetes may be rather similar across the core diabetes, the main diabetes types, type 1 and type 2. Then with regard to this core aspect of fear of complications or fear of progression, one important aspect is to see that the risk of fear of complications is usually overestimated. People think they are at higher risk of blinding, of losing their eyesight, of having kidney disease with dialysis dependency, or even having amputation. They are estimating a higher risk than there's actually on average there is. So obviously this may result in higher fear regarding these complications. And then, as I said, there's hypoglycemia as one significant acute complication that is also often associated with worry and fear. So these are some of the core aspects of diabetes distress, diabetes-specific emotional burden, you could say. And diabetes distress is associated closely with depressive symptoms. There's across many studies a high correlation. That is not very surprising. But then there's people, a minority, but there are people having depression without diabetes distress also, and having diabetes distress without depressive symptoms also. So you can distinguish those closely related, but still distinct or still to be distinguished mental variables. Diabetes distress increases the risk of developing depression and also increases the persistence of present depression. So it's more likely to be chronic according to longitudinal results. And if you distinguish those two variables in a 2-by-2 design, you will find, of course, a majority of people not affected by these variables, by these affective conditions, but then many people having both, actually. That is what we see a lot. People having depression, usually also experiencing higher diabetes distress, and then people with either depression but no distress, or diabetes distress but not depression or depressive symptoms. This is usually less common, according to what we see in our center, than the comorbidity of both, or the concomitant occurrence of both. These are results from one of our screening studies, where about 2,500 participants, people visiting our center, were screened systematically for these aspects, and we found less than 50% unaffected by any of these aspects, while almost 6% had diabetes distress but no depressive symptoms, 21% with depression but no diabetes distress, and 1/4 of all with both concomitantly. So you see, it is quite common, according to what we see here, that people have depressive symptoms and diabetes distress concomitantly. And we expect that this concomitant occurrence, well, is associated obviously with the least optimal quality of life, that's for sure, but also with a higher risk compared to the other groups, higher risk of suboptimal outcomes, suboptimal glucose control compared to the other groups. So there's risk models or explanatory models showing the impact, the negative impact of depression and diabetes distress on glucose control, on self-management of the condition, and maybe other impacts on glucose control. So potential negative impact of depression and or diabetes distress on glucose control may be mediated by less optimal treatment behavior, non-adherence, less optimal lifestyle, maybe smoking, inactivity, and other lifestyle factors that can influence outcomes. But it may also be mediated by physiological mechanisms such as stress reactivity, chronic low-grade inflammation, and stress axis, HPA axis activity. So there's also an important factor to look at the physiological side, not only at the behavioral side. And this model that I'm showing here is a highly theoretic model, but it's rarely tested. It has rarely been tested empirically, and if it was tested, then mainly cross-sectionally and not really in a longitudinal design. So you may look at potential causal effects. So it's only about associations. The state of the art of research is rather limited here. There are some studies looking at the 4 different groups, distinguishing these groups, as I said, and there is some evidence suggesting that the group with depression and concomitant diabetes distress may have a higher risk of poor outcomes, such as higher HbA1c, which is less optimal glucose control. There are several results, but this is also cross-sectional research. So to sum this up, the research strategies that have been applied up to now, mainly cross-sectional studies, mostly cross-sectional studies. If longitudinal, then mostly treatment studies, not observational, looking at the effects, but looking at treatment effects on depression, for example, and then maybe looking at potential secondary side effects on glucose outcomes, etc. Few of those studies analyzed associations between the independent and dependent variables, considering mediators or moderators of these associations. Mood variables such as depression or diabetes stress are assessed in a global static way using questionnaires or potentially interviews, considering a longer period of maybe 2 weeks or 4 weeks, but not within a day or within situations of low glucose, high glucose. The situational associations of glucose variations and fluctuations with mood and negative mood and stress levels and potentially depressive feelings have not been considered at all. So to understand the associations, it may make sense to look at these details much more closely than having an eight-week HbA1c value reflecting the mean glucose over 8 weeks and having a mood rating for the last 2 or 4 weeks. So this is quite global, and we wanted to go into the smaller associations and relationships impacts here. And yeah, that's how we came planning and setting up the dialing study. First the type 1 study, and now, as I said, type 2, which are observational, prospective observational studies over a time period of about 3.5 months per participant, with a baseline assessment, obviously with standard questionnaires regarding depression and the like. Then an ambulatory phase, which is kind of the core period over 4 weeks, a small post-assessment after the 4-week period, and then after 3 months, after the baseline assessment, 3 months later, there's a follow-up, including also more global outcomes such as well, depression values, HbA1c laboratory value and stuff like that. But the more detailed microanalytic approach lies within the 4-week period, including continuous glucose monitoring. So we are collecting the glucose levels per 4 times per hour, at least 4 times per hour over the 4 weeks in full. If people adhere, we are collecting really all those data. That's more than 100 glucose values per day. We are collecting mood ratings, stress experiences, stress factors, diabetes problems and burdens each day. Over the day, we're collecting mood aspects, specific moods each day. So we're really able to see variations over the days in the subgroups, across the groups, associated with variations in glucose. And this is the approach of this study. Then one important aspect also is that we are enrolling 200, more or less 200 persons per study. In the type 1 study, the recruitment is finished, and we ended up with 208 being enrolled, 203 being able for analysis, being suitable, 5 who dropped out and didn't provide much data at all. But let's say 203, of which it was planned to have 4 groups, stratified sampling by the 4 groups with either no elevated depression or distress, or either depression or diabetes distress elevated, or both. So we are creating an artificial but kind of optimized distribution of those mental variables, depression and diabetes distress, within the sample. It is not a large sample with 200 persons, but still you're collecting data cross-section prospectively, so it is a lot of work with 200, especially in the time frame of 2 years. And we are creating an optimized distribution of these core aspects within the sample. And then there's the core variables based on questionnaires such as depression scores, diabetes distress scores, and HbA1c as the valid laboratory assessment of average glucose control, which are measured repeatedly over the study. Within the 4-week period, we are collecting, first of all, glucose, the glucose level over each day, 4 times per hour at least. I mean, 4 values per hour are kept in the memory of the reader. And then each time you scan your glucose using this system, the scanned values are also kept, but it's at least 4 times per hour. It's about 100 and something values per day over 4 weeks. So you can really follow the glucose levels over the day, as you can see in the small diagram here. And then simultaneously, we are collecting aspects of general mood being rated also 4 times a day in the MIMA surveys. How's your general, what's your mood right now? Are you feeling good, feeling bad? What's your stress level? Are you feeling stressed right now? And then other aspects, specific mood aspects, specific factors of diabetes problems, other stress factors such as social and work-related problems, and sleep. Sleep quality is also assessed in the MIMA surveys. And then a third aspect is we're collecting heart rate and activity measures such as step count and number of intensive activity minutes, or minutes of intensive activity per day, calorie count per day, and the like, which is collected by a fitness tracker, a health tracker, a watch that people are wearing during the 4 weeks, and it's measuring these variables. And as Catherine said, they installed an option to collect the data in the MIMA app over a live stream. So we're actually collecting all those measured data each second. It's a live stream, and you get 1 heart rate value per second, and a lot of data. These are really large data files, and we are trying to find now ways to analyze all this in association. But it is quite interesting to see heart rate variability and also step count as a measure of activity levels in association with glucose levels and with mood aspects. So we are able to see the different mental and physical processes in association. This is how CGM works using the Freestyle Libre sensor that we are applying. It is a small sensor being worn on the upper arm, on the back side of the upper arm. You can wear it up to 14 days, and it is measuring glucose in the liquid between your cells continuously at any time, and the values are kept in the memory each 15 minutes, and people can see their results if they scan with the reader, scan the sensor, and you see the small tool. It says 140 milligrams sugar per deciliter blood, and this is the trend. It is going up, or it is going down, or it is stable, stuff like that. And you can see the course over the last hours. So it is really a lot of information for the participant, of course, but for us collecting the data, of course, too. You can see the data file here. It shows the single values per each 15 minutes. It's 6 p.m. 132, 6:11 p.m. 114, and so on. You can see at least every 15 minutes there's one value for the blood glucose. And we are aggregating this and associating it with mental variables. Now, the MIMA assessment may be familiar for you. You may be familiar with it. The app will say time to take your survey. There's an alarm. People are asked to answer some questions. One survey in our assessment takes about 1 minute. We have 4 in the morning, around noon, in the afternoon, and in the evening. The evening survey may be up to 1.5, maybe 2 minutes if you're slow. It's between 10, 12, and 20 questions, rather quick and focused on different aspects. In the mornings, it's about how you slept and how you're feeling right now. In the noon and afternoon times, it's about different mood aspects, and again, general mood, stress level, energy levels, and in the evening, it's kind of a hindsight over the day, feedback, stress factors, stress levels, diabetes problems, areas where you had kind of problems potentially, and the like. So this is how the questions look like. It's German questions. So this reads, how is your mood right now from 0, very poor, to 10, very good? How stressed are you feeling right now from 0, not at all, to 10, very much? Then specific mood aspects, which are actually based on the University of Wales mood objective checklist, such as how dull are you feeling? No, are you feeling dull right now? No, rather yes, yes. Are you feeling angry right now, and the like? The response scale is based on the questionnaire itself, on the original scale, so it's no, rather yes, yes. And we are assessing different aspects of tense and energetic arousal and hedonic tone and anger, which are the 4 scales of this checklist, to understand aspects of mood over the day and within days more specifically. We are looking at general sources of stress, such as the field of diabetes, the social field of family aspects and work and tasks. How much have you been burdened by stress due to diabetes today? Not at all, very much. How much have you been burdened by stress due to your family and partner relationship or friends today? Social field. How much have you been burdened by stress due to your education, your work, your important tasks today? So this is quite general. Then more specific with regard to diabetes are questions based on the paid questionnaire, which were revised for being used in within the survey here, which are, for example, how much have you felt restricted by your diabetes today? How much have you felt overwhelmed by your diabetes today? How much have you felt alone with your diabetes today? How much have you felt your diabetes is taking up physical or mental energy today? How much have you felt guilty or anxious when you came off track with your diabetes self-management, and so on. Different aspects and usual problems that we expect to be common in people, but this has never been assessed in a daily assessment. We only have used these questionnaires, and all those studies out there regarding diabetes stress have only used questionnaires over the last 2 or 4 weeks. So this is quite unusual and innovative. Then there's aspects of sleep quality based on the Pittsburgh Sleep Quality Index, such as subjective sleep quality and total sleep time and sleep efficiency, which you see sleep is obviously negatively associated with depression and other stress factors. And then, as I said, there's the fitness tracker, or the Garmin watch, that is collecting heart rate and aspects such as steps and intensity minutes, or minutes of intensive activity per day. So we are quite curious now how these relates to the other core variables. Inclusion, exclusion criteria, this is not too interesting right now. As I said, we have a baseline assessment, 4-week ambulatory phase post-test, and 3-month follow-up, including all these aspects. Also, we're collecting inflammatory markers, actually 6 different markers of inflammation, such as C-reactive protein, several interleukin values, adiponectin, MCP1 or CCL2, that's the same. At the baseline assessment, we're collecting cortisol levels within the 4-week period, 4 days within the 4-week period, where people take saliva specimen for enabling estimation of cortisol levels. So there's a lot of different aspects, not only mental, but also physical and somatic, physiologic variables of interest. I'm skipping a few of these slides, not too interesting. Follow-up assessment. Yeah, we're actually looking at a lot of associations which may be there between, well, general depressive symptoms and diabetes distress with daily aspects such as daily hassles or stress levels or mood, with sleep quality, with activities, with how people treat their diabetes, with somatic aspects or physiological aspects such as cortisol levels, for stress reactivity, inflammation, heart rate variability, and the associations with glucose outcomes. On one hand, the HbA1c value as the laboratory value for average glucose over time, and then the variables derived by the CGM system, which is time in range, how much time were the glucose values in the target range over the day, or out of that in hypo or hypoglycemic areas. And yeah, we're looking at a lot of different associations. I have a lot of questions and hypotheses. I'm not going into the details now. With looking at the time, we need to finish. And now just a brief view at some of the initial results from the DIAL-LINK 1 study. We ended up with not really 50 people per group, a few more in 3 of the groups, as people kind of sometimes dropped out or didn't provide sufficient data. We recruited some more, but then in the depression-only group, we didn't really get to the 50. We might have got there, but then the corona lockdown interfered, and we had to finish the enrollment, and now it is like that, but it's quite good. And we have a rather young population, as it is type 1 diabetes in this DIAL-LINK 1 study, with rather balanced gender distribution, with a long-standing diabetes illness, long duration of 19 years, but it is type 1, so people were diagnosed or developed type 1 diabetes early in their lives. Many people having used CGM previously. HbA1c at baseline identifies that people are in poor control with 8.7, that's suboptimal glucose control. And of course, we have high prevalences of diabetes distress and depressive symptoms, as people were collected based on these criteria in some of the groups. And we have a lot of mood ratings in the MIMA assessment. We have a lot of glucose data, single values from all these people, with, you can see average mood ratings around 6 of 10 points in the moderate range and with variation. So we have some variation to look at. We have mean glucose levels around 180, which is out of the range on average. We have only 55% of values in the range, in the target range, while 42% of all values are over the range in the hyperglycemic area, and 4% are in the hypoglycemic area. So it is a lot of information that we have to look at and analyze the associations between these glucose aspects and moods, stress levels, and depression. And then some preliminary results, just very brief. It is unpublished data. With regard to the 4 different groups, no depression, no distress, diabetes distress only, depression only, and the 2 conditions concomitantly. And as I suggested, you have a higher mean glucose level on average in the double problematic group in the depression plus diabetes distress group. And also interestingly, well, yeah, that's mood ratings. So as would be expected, you have the least optimal mood, the lowest mood, or the most depressed mood in the depression plus diabetes distress group. But interestingly, you also have a lot of variation there. The coefficient of variation is the highest in this group. So it is not only people are least happy, you could say, they also have a lot of swings and variation, which may also be an issue, having this variation. We submitted some of our preliminary results up to now to the concurrent conventions, such as the European Association for the Study of Diabetes convention in September, looking at some of the daily diabetes, most significant daily diabetes problems and burdens and their associations with glucose outcomes, feeling guilty, feeling overwhelmed, and feeling alone with diabetes were significantly associated with higher glucose levels and more glucose variability too. That is interesting. And well, to sum up where we are going with all these data, we're trying to identify patterns. We're trying to identify the moderators and mediators within these dire links, and this shall be the basis for developing personalized interventions ultimately. Okay, I think I'm a bit over time, excuse me for that. I hope this was a good overview of the dire link studies and what we try to do here, and why this may be important, or why we consider this very important. And yeah, I'd like to thank you for your attention.
Thank you, Andreas. Yes, this was wonderful. What a lot of information. I'm still like trying to process it, and really appreciate you giving us the details. It was great to see like some of the data sheets from the different, like from the Freestyle Libre device, and like get into some like real details about what these data look like. I know we have a question from Shivani. Shivani, do you want to unmute yourself and ask Andreas your question?
Sure. Hi, thank you so much for that talk. I actually know Dominic from your team, and I've spoken to him before.
Oh yeah, you know him.
Yeah, I'm familiar with the dialing study, but I wanted to know, and it's great that now you're also looking at type 2 groups. I'm wondering how you're planning to use this data for just-in-time adaptive interventions. You know, if the goal is to inform clinical interventions, or keep this, like you said, precision medicine, and what kind of data from what you collected might be momentary and actually elicit an intervention that could be at the time of, you know, momentary, where the person is.
Yeah, I get your question. I think first of all, there has been a significant research effort to trying to understand whether depression impacts on diabetes control, on diabetes treatment. Well, I think the evidence is good for impact on diabetes treatment, but not on glycemic control. In which way may it impact on glycemic control? Which are the pathways? What are the pathways? And then, is it depression? Is it diabetes distress? Is it depressive symptoms? Is it the interplay, the concomitant effect maybe of these two? Does depressive mood need to be closely associated with diabetes problems, for example? You could interpret the concomitant presence of depression and diabetes that way. We do not really understand right now what triggers higher risk, less optimal treatment behavior, less optimal glucose control, higher risk of complications. So we really need to understand what are the causal relationships, and then we can say you need to focus this variable. I mean, the group, you need to focus depression, you need to treat depression to increase the likelihood of getting better diabetes outcomes, better quality of life, of course, but also better health outcomes in these people. Or you need to focus on diabetes distress in the first place, or on the concomitant presence of both. or whatever. We really need to understand what is the high risk group and how does this work. And if we understand that, we can, well, set up, establish, develop interventions focusing at the specific needs of these groups to tailor our interventions. And this is the ultimate goal. But as I said, there's a lot of hypotheses and models, but the study evidence is quite diverse and not very consistent across studies. And also the methodological quality is not very good if you have a majority of cross-sectional studies.
Right.
We really need better insights. So this is how we try to approach this.
Got it. Thank you.
Thank you, Andreas. We have another question from Simon.
Hi, Andrea. I really appreciate your talk. I have a few questions on the logistics side on how you pull out this wonderful study. One specific question is, how is the dropout rate of the patients participating in the trial? You have a fairly sophisticated sensors on the body with all the ecological moment assessment. So that's one question. And the other question is, what are some of the, you mentioned you have about 200 patients in the study. How do you deal with the logistic of the loss of equipment? Do you see a lot of them happening?
I'm afraid I had some problems understanding the question well due to the auditive. It is kind of not very loud, you know. I understand the first question regarded the measurement approach using sensors and tracks, the tracker and collecting the kind of objective data.
And the dropout rate, Andreas, what was the dropout rate for your
the dropout rate
study?
It was not too much. It was a rather low dropout rate, fortunately. I think it may have to do with people's interest in the topic. I think there's a lot of people with type 1 diabetes that found this study and approach and the topic quite interesting and valuable. And they were keen in taking part, participating in the study. And also they appreciated receiving the tracker, for example, and getting some insights based on the data collection in their personal glucose control and diabetes mechanisms, you could say. So we had the highest dropout rate within the depression plus diabetes distress group. And as usual, from my point of view, based on the studies that I conducted, it is more the younger people who kind of, well, drop out, tend to drop out compared to the older ones. I think they may sometimes be less encouraged to stay, like saying, what I begun, I will finish. But if they lose their interest, they just drop out. So it is dropout, especially in the most severely affected group, depression plus diabetes distress, and then it is also the younger ones. And how many were there? We had 208 enrolled, and I would say, I'm not totally sure, but we ended up with follow-up assessments and getting most of the data, complete or almost complete data sets for about 180, including the follow-up assessments. So it is not too many who really dropped out of the full study, and most participants also finished the 4-week period and then may have some dropped out at the follow-up assessment. So the majority, most of them finished the 4-week period, and then we had some dropout when it came to the follow-up assessment.
Yeah. Thank you. And Hyung-Wei had a similar question about the completion rate of the MIMA surveys. Do you have any data on the completion rates?
Once again, please. The
completion rates of the MIMA surveys, like the compliance level with the mobile surveys.
Yeah. Well, based on the adherence overviews in the surveys, I would say we had maybe half of our participants really adhered to the scheme, conducting all or almost all of the 4 surveys per day. So almost 100%, maybe 90 to 100% adherence. That is maybe 50% of the participants, and then there's, yeah, well, less, maybe 1/4 with over 60%, and maybe 1/4 with 50 or less. Yeah, specifically in the group with depression and diabetes distress, we had some dropouts who really dropped out within the 4-week MIMA period, explaining my depression became so severe recently, I don't want to concentrate on this survey anymore. I'm out of here, kind of that, you know. So it is mainly the most severely affected group that sometimes even stopped the 4-week assessment, but most finished the 4-week period, and we had really good adherence, I would say. And then of course some people doing like 2 to 3 surveys per day rather than 4.
Right, which leads into Tyler has another question, which I'll let him ask, but it sounds like he's asking about the impact of the continuous glucose monitors on people's state of mind, their depression, their stress levels, and if you saw that having access to that monitor actually changed how stressful it was. Tyler, do you want to add to that?
Oh, that was a perfect summary. I'm really just getting at, you know, is it too much information, or, you know, for someone with type 1 diabetes, from what I've heard, they're pretty much always thinking about it, or at least have to think about it hourly and before every meal anyway. So have you seen that relationship between CGM use and improving, or any relationship to diabetes related stress?
Very good question for sure, but I'm afraid I think we're not at that point yet. We're just starting to get into the data and to analyze the data. So I can just sum up my impressions, but I think not based on the study data yet. We finished the data collection recently during the lockdown, and now we're starting to really analyze it, but I'm afraid I cannot answer that yet. I mean, for sure, people with type 1 diabetes are thinking about their diabetes, at least managing their diabetes at least 25, 30 times a day. People really concerned with their diabetes, with their type 1 diabetes, maybe thinking about their diabetes 50 to 100 times a day. It is really part of their daily living a lot.
Right. And it sounds like the methods that you're using, Andreas, that are capturing so much data throughout the day, is that kind of approach is going to be able to give us these kinds of answers as to the dynamics of how these things work together for an individual, because you're not just taking snapshots of data, you're really collecting an almost continuous stream as they go throughout their daily lives. Yeah. Thank you for sharing this. This was so fascinating to hear all of this. Again, I get to work with you in a different capacity, usually around like, what do we need to do now with the app? But to actually hear the results of the work that you've been doing and see some of this data coming to life is, for me personally, very fascinating, and really appreciate you taking the time to share it with us.
Yeah, thank you very much too.
Yeah.
It was a pleasure to be able to present this approach and the preliminary insights, and also to have a nice discussion and interest. Thank you for the good questions to the audience.
we'll be making this recording available. I'll send out an email soon with the recording. So if there's anyone, any colleagues you know that you want to share it with, it'll also be available on the IllumiView website. I'll send that link out too. And our next one, I think, Hongwei, right, is scheduled for actually at this point the end of October, although we may be able to get one in September. So we'll certainly send out an email and let you all know. Thank you, everybody, for joining us.
Thank you.
Yeah, thanks, Andreas.
Thank you. Goodbye.
Bye.
Bye.